Welcome to the American Heart Association Statements and Guidelines podcast, where we'll discuss clinical practice guidelines and scientific statements on various cardiovascular disease and stroke topics.
Hello, everyone. I am Dr. Chiadi Ndumele.
And I'm Dr. Janani Rangaswamy.
And today we're talking about the American Heart Association's new Presidential Advisory on Cardiovascular-Kidney-Metabolic Health. I am a cardiologist and an associate professor in the Department of Medicine at Johns Hopkins University. I care for individuals who are either at risk for or have existing cardiovascular disease. I also do research that's focused on the relationship between obesity and the development of cardiovascular disease, considering both biological pathways as well as social factors related to that relationship. I'm also lead of the Strategically Focused Research Network on Cardiometabolic Health. That's at Johns Hopkins. And I am chair-elect for the American Heart Association's Council on Lifestyle and Metabolic Health, and very passionate about understanding how to address issues around cardiovascular kidney metabolic health for my patients and patients of other people as well. Janani?
And I'm a nephrologist. I'm a professor of medicine at the George Washington University School of Medicine. My clinical work is at the Washington, D.C. VA, and I'm the chair of the Council on the Kidney and Cardiovascular Disease. My clinical and research passion and niche is in all things overlapping between the heart, the cardiovascular system, and the kidneys. And it's such a pleasure to be part of this project and do this work with you, Chiadi.
Yeah, it's really quite a pleasure. And both of us have had the pleasure of serving as co-chairs for this initiative. And we are, as Janani described, a nephrologist and a cardiologist that are coming together to talk about cardiovascular kidney metabolic health, as well as cardiovascular kidney metabolic syndrome, which we also can refer to here on as CKM Syndrome. And this is really a concept that's relatively new that we believe can redefine both heart disease management and prevention, and can start to break down some of the silos in healthcare, as represented by the two of us coming together. And our hope is that this will really be a game changer for how we approach heart disease. There's a focus on a life course approach to considering prevention and management, starting with the root causes of CKM syndrome. There's really a focus on multiple organ systems, as well as the social context in which this condition presents itself. And that really lends itself to thinking about the whole person and having a more holistic approach to considering prevention and management. And also because one of the major goals of this is to reduce the fragmentation of care, this advisory is really for anyone and everyone in the healthcare field. It's not just cardiologists and nephrologists. It's also for primary care physicians in particular who are going to see a lot of the patients along this spectrum, endocrinologists, as well as nurses, diabetes education specialists, and even dentists. So we really want to engage all of the individuals within the healthcare system, because this is really a problem that touches on most specialties and most areas of clinical interest. And really, the goal is that for all of us to understand CKM health together, and as a result, then we can all work together to keep our patients healthy. And this is really about a patient-centered, integrated approach to preventing and managing heart disease.
I think you summarized that so well, Chiadi. And, we've been working on this advisory for quite some time now, and we're so excited to share this cutting edge content. And importantly, as you say, a lot of the pathophysiological interplay between the cardiovascular system, the kidneys, and obesity and diabetes are well established. But I think we've just, been able to bring the interplay to the forefront. And, I think a large part of why this was possible was the huge group effort. We had 36 cross-disciplinary experts contribute not just their expertise as writers and thought leaders, but also as reviewers. And they come from so many, a myriad of disciplines: nephrology, cardiology, endocrinology, primary care, pediatricians, pediatric cardiology, and we're, like you rightly said, looking at encompassing the whole lifespan and health span in that lifespan. So I really think this project has so many unique dimensions that we're so excited to share, but I really think that holistic approach is really the big thrust.
So that's absolutely right. And the first thing that I think is important is to understand why this is important. Why is CKM syndrome such an important challenge? So, first of all, it's exceptionally common. At least 1 in 3 US adults have 3 or more risk factors for CKM syndrome, representing at least 90 million individuals. But really, the most important challenge related to CKM syndrome is premature mortality. And that premature mortality is primarily due to an excess burden of cardiovascular disease. And what we know is any one of those CKM syndrome components that we're going to be talking about is related to premature mortality. But when there's a confluence of those factors, as we often see in clinical practice, that has a synergistically increased risk of mortality. Secondly, as Dr. Janani said, we also know that all these systems of the body are connected, but that's not always reflected in our healthcare system. We have lots of challenges with fragmentation of care. And anybody who's taking care of a patient, whether you're a primary care physician or a subspecialist, has easily seen challenges where a patient says, "Who do I listen to?" People are talking from different playbooks, and their recommendations are sometimes a little bit divergent. Additionally, we know that some patients, particularly those from more socially disenfranchised backgrounds, have even more challenges with navigating the health system and addressing multiple subspecialists and multiple comorbid conditions. And that's leads to another important point, which is addressing social determinants of health. And social determinants of health are remarkably important to considering CKM syndrome. They're related to the development of CKM syndrome. They're related to who gets identified early as having some of these CKM syndrome risk factors. They're certainly related to the care for CKM syndrome, both self-care as well as care within the context of the health system, and they're related to the likelihood of complications from CKM syndrome. So considering the person and their social context is a really important component of what we're going to be focusing on here today. So as part of what we're going to be discussing, we're going to give you an overview of the most important aspects of CKM syndrome and its care so you can put this holistic approach to care into action, no matter what your role is in the healthcare system.
I think you stated that beautifully, Chadi. And along with holistic comes equitable care. And I think you just touched upon that really well in terms of how social determinants of health directly influence upstream the course of cardio-kidney metabolic syndrome. So, Chadi, when we started this work, we were charged with coming up with a very simple and powerful definition for what is a very complex syndrome, as we have just been talking about. And we defined CKM syndrome as a health disorder due to interactions among heart disease, kidney disease, diabetes, and obesity, resulting in poor health outcomes. And I think that is, a powerful way of stating that both in medical terms and also to educate the lay public as well as our patients. But it's also important to point out that cardio-kidney metabolic syndrome is not just limited to the systems we just talked about. It is truly a multi-system disorder. It affects brain function, liver function, every organ, just about every organ is involved in this systemic condition. And again, coming back to the central theme of our work, we really want to approach this as a whole patient in a holistic process. And we are really well equipped and poised to do that now because a lot of the therapies previously used to diverge, where benefit to one organ would actually result in harm to the other. We now finally have therapies that actually converge together and meaningfully improve outcomes, whether from a metabolic perspective, a cardiovascular perspective, or a kidney perspective. And this is really, very personal to me, as when I started my career as a nephrologist and started developing interest in the cardio kidney space, it just brings back memories of premature death and loss of patients with kidney disease. I remember rounding in dialysis units. You get really close to these patients, you see them week after week, and then one day that chair is just empty. And then you realize they suffered an MI, they had a major stroke, and the excess cardiovascular disease burden that we have focused on and that we are attempting to change the trajectory of is truly deeply personal. As a nephrologist and having lost so many patients from deadly cardiovascular outcomes, I really think this work really is game changing.
I think that's a really beautifully said, and a really great point about the deep relevance of this work to us as clinical providers. And I think it's important as we consider this, we understand what the different components are of CKM syndrome. So the C, of course, is cardiovascular, and the K is the kidney and chronic kidney disease, and the M is really or stands for metabolic conditions. That's the M in CKM. And those are conditions like obesity and type 2 diabetes, which are really powerful risk factors for cardiovascular disease. And these are all really closely interconnected. So what we know is that obesity is really strongly and causally linked to the development of diabetes, as well as some other what we call metabolic risk factors like hypertension and also certain kinds of dyslipidemias. We also know that diabetes and hypertension are very closely linked to the development of chronic kidney disease, in fact, the most common cause of those. And then we know that if we put those together, that basically the combination of these metabolic risk factors and chronic kidney disease markedly increase the risk for the development of cardiovascular disease. I actually had a patient not that long ago that was just so flustered with the fact that she had all these different health conditions and that she was seeing endocrinology and nephrology and cardiology and just wanted to understand why she had such bad luck in this regard. And really, when I was able to explain to her this interconnectedness of all these conditions, it was like a light bulb went off. And then she understood why it's so important for all of her healthcare providers to be working together and communicating to really give her the most comprehensive and holistic care. These constellation of risk factors that come together in CKM syndrome really ultimately result in significant organ damage. And what's important to recognize is that it starts early. So it's not, we're trying to basically start to identify individuals, not by the time they've already come in with a heart attack or have already come in with heart failure or atrial fibrillation. We want to start identifying individuals earlier in the process so that we can actually prevent their progression to worsening stages of this CKM syndrome. It's also worth emphasizing that obesity and diabetes and their historic prevalence are driving a lot of what we're seeing, but this is not just happening in adults, it's happening in youth. And we're seeing the early emergence of not only obesity, but and diabetes, but these other downstream effects. And that's why the approach that we're using to considering CKM syndrome and its staging actually starts early. We're doing it both among youth as well as among adults.
That is such an important point, Chiadi. And as they say, an ounce of prevention is better than a pound of cure. And I think nothing is more true in the context of CKM syndrome. Like you said, we have generally focused as a medical community on treating disease well into its established state. And I think, there is so much opportunity we have today, especially with what we know about the effects of lifestyle modification, nutrition, as well as some of the powerful cardio-kidney metabolic therapies we have. And we have an opportunity to really change the trajectory of what is considered inevitable progression of disease. It doesn't actually have to be inevitable. And I think that is the frame shift in our thinking that we really need to adopt. And to kind of show that progression of disease and the ability to stratify by risk and also address risk according to the different phases of CKM syndrome, we came up with this staging system. And the first of those is stage 0 cardio-kidney metabolic syndrome. And these are healthy individuals without obesity or metabolic factors like hypertension. And the main focus is for these patients is to keep them in stage 0, which is the ultimate goal of prevention. And to that end, basic lifestyle modification and following the principles as beautifully outlined in Life's Essential 8, healthy eating, being active, avoiding smoking, maintaining healthy weight, blood pressure, sugar, and lipids is really critical.
That's a really great point. And we know that even in those healthy adults, still doing some degree of screening and assessments leads to more equitable identification of some of these risk factors at an early stage. And then we have our next stage, which is stage 1. And in stage one, now we're focusing on excess body fat and or an unhealthy distribution of body fat, as well as individuals who have evidence of impaired glucose tolerance. We know that addressing this is really at the root of most of CKM syndrome, and it's so incredibly important, but it often goes unaddressed. And I think one of the reasons it goes unaddressed is because we often view issues around obesity as individual challenges or failures of willpower, as opposed to as a more complex systemic challenge that includes considerations of not only biological factors and predisposition, but also multi-level social determinants that impact our behaviors and that impact our likelihood of developing obesity. So understanding that complexity can lead to, I think, more effective ways of engaging with that with our patients. We also, in stage one, focus on some individuals who have impaired glucose tolerance. And that's important because there's a lot of heterogeneity among individuals. And there's some individuals, even in normal weight categories, and this is more likely to be the case among non-white individuals, but even in normal weight, where we see evidence of dysfunctional adipose tissue leading to impaired glucose tolerance and eventual hyperglycemia, even in the absence of excess weight. So we're covering individuals with hyperglycemia, abnormal body fat distribution, or excess body fat as part of that stage. And our goal is to prevent those individuals from progressing to the next stage with more metabolic risk factors or chronic kidney disease and more abnormalities that could lead to cardiovascular disease. So our focus here is to really suggest healthy lifestyle changes. We also want to really have that goal of at least 5% weight loss, where we start to see some improvements in the glucose intolerance, as well as reduced likelihood for developing some of these metabolic risk factors. In this stage, we advise screening every 2 to 3 years to assess blood pressure, lipids, and blood sugar. And I will tell you that awareness and appropriate engagement is really important in this stage. I just recently connected with a relatively young person who was in this stage one and found out that he had a lot of borderline risk factors, but he found out that he had prediabetes. And once he found that out, his concern around that really led him to make some really remarkable changes to the structure of his lifestyle that resulted in substantial weight loss and improvement in not only his glycemia, but other metabolic parameters.
That is so heartwarming to hear, Chiadi. And I completely agree with you that, sometimes patients are even hesitant to discuss this with their clinicians because there is so much stigma and there is so much judgment, including self-judgment. A lot of patients truly blame themselves for
Yes.
their adiposity. And I really think it is so important to keep that open environment in a non-judgmental way and address what is truly upstream to the development and progression through all these stages. And it's truly not an inevitable course that patients have to
And,
take.
and the data is so compelling, Janani, that it's not just engaging individuals, it's how you engage individuals. And those individuals who are engaged in that non-judgmental fashion, they are much more likely to have successful efforts at weight loss. So I think that you're absolutely right. It's important for us to understand how prevalent that stigma and bias is within even the healthcare setting.
You're absolutely right, Chadi. But when that progression does happen, and it can happen for a variety of reasons, then when patients progress to stage 2 CKM, this now encompasses patients with metabolic risk factors or kidney disease. So these would include patients with established hypertension, type 2 diabetes, metabolic syndrome, dyslipidemia, or chronic kidney disease. It is so important to note here that even though there can be clustering of multiple risk factors in stage 2 CKM, many patients are completely unaware. They are completely unaware that this cumulative risk is adding up, and these factors work in synergistic ways to add to that excess cardiovascular disease burden. Now, talking about chronic kidney disease, Chadi, it is really important to point out that in the United States, 90% of patients with CKD don't know they have CKD. And even in those where it may be first detected for example, with an abnormal EGFR, it isn't properly risk stratified because you actually need two elements: an estimated GFR using a glomerular function marker, but you also need another component, which is the urine albumin to creatinine ratio to establish baseline albuminuria. And when you put these two metrics together in a well established risk heat map, which has been pioneered by KDIGO, you can appropriately stratify patients. You can even show them where they are on this risk grid, because the risk grid is important for two reasons. It shows the risk of progression to kidney failure, but it also shows the risk of cardiovascular adverse events, and these go hand in hand. So I really think there has to be a huge shout out from the rooftops to screen for albuminuria, especially in patients with underlying risk factors.
That's really helpful. And, it's worth recognizing that there's this really powerful interplay between these stage two factors. So, obesity and diabetes and hypertension leading to CKD, CKD leading to worsening hypertension, metabolic syndrome within that leading to all these factors and encompassing these factors. So, it's probably worth calling a little bit of attention to diabetes and CKD, where we've spent a lot of time thinking about the approach to those conditions, and recognizing the importance in diabetes of this growing array of cardioprotective therapies, particularly the SGLT2 inhibitors and the GLP-1 receptor agonists, and wanting to make sure that in those individuals who have certain comorbidities like CKD, or who have very significant obesity or significant hyperglycemia, that we're emphasizing the use of these agents, GLP-1 receptor agonists to think about addressing weight and glycemia in a powerful way, SGLT2 inhibitors to think about addressing CKD.
Absolutely, Chiadi. And like you rightly pointed out, the SGLT2 inhibitors are truly one of those foundational unifying cardio kidney protective therapies. And we now have a rich body, high level evidence backed body of literature now supporting broad use of SGLT2 inhibitors in patients with chronic kidney disease, those with and without diabetes, those across the strata of albuminuria, and as you know, in patients with heart failure across the EF spectrum as well. So very, very broad implications, but comorbid CKD should be a huge trigger for the thought process for the initiation and maintenance of an SGLT2 inhibitor. In patients with a confluence of diabetes and CKD, another agent, finerenone, has also gathered a lot of attention. And now we have good data, both from the Fidelio DKD trial, as well as cardiovascular outcomes in patients enrolled with diabetic kidney disease from Figaro and the pooled analyses of Fidelity, showing additional benefits on top of ROS inhibition. And the future will be really exciting to see. And you brought this point out in a very nice way about who do we combine therapies in? Who is a candidate for one or both? And in the highest risk populations, is there a role for an SGLT2 inhibitor plus the GLP receptor agonist and or finerenone? So I think a lot of studies ranging from mechanisms to clinical outcome studies will shed light on those questions. But it is such an exciting time to be able to care for these patients.
It really is. And I think the one last thing I'll say about that is that, we now have this increasing array of these therapies that affect multiple systems, right? Affecting the kidney and the heart and the metabolic outcomes, as well as, differing effects of these different agents. But what we need is the roadmap to better understand how and when we deploy these therapies, particularly in that at-risk population that doesn't yet have cardiovascular disease. So that's, I think, been a key focus of ours to try to help individuals make sure these therapies get to where they need to go.
Absolutely. And like you said, our staging system takes that qualitative angle, and our risk prediction calculator, which will be unveiled in sessions, will hopefully add that quantitative perspective as well. And I think it truly helps move the needle in terms of more precision in terms of that risk stratification and appropriate deployment of therapies.
The next stage of this progression is stage three. Now, one thing to point out is that as we've gone along, our stages have both reflected the pathophysiologic progression of CKM syndrome, and they've also reflected increasing absolute risk, both for cardiovascular disease and also for kidney failure at the same time. So our risk, as we're going up and up in risk, there's an intensification of our therapeutic approach to reflect that greater absolute risk for their patients, where we're going to get even more bang for your buck with a therapy, more absolute risk reduction. Stage 3 is when we're starting to see early cardiovascular disease or subclinical cardiovascular disease in the absence of symptoms. So that's kind of subclinical cardiovascular disease or some risk equivalents. So those are some individuals who have very high risk chronic kidney disease using EGFR and urine albumin creatinine, just like Janani just spoke of, or patients with high predicted risk using the new risk calculator, which I'll talk about in just a moment. So in terms of subclinical disease, we're now talking about not just atherosclerosis, but we're also talking about heart failure. So we're talking about subclinical coronary disease reflected by coronary atherosclerosis, or an individual could have that noted on a CT angiogram or on a coronary cardiac catheterization, or an individual who has subclinical peripheral arterial disease. The reason why this stage is important is because it really reflects a group that's fairly far along in terms of their risk. And we also should point out that that group is having that subclinical disease overlapping with the earlier CKM risk factors, so like obesity, diabetes, hypertension, metabolic syndrome, or chronic kidney disease. So that group is somewhat far along in their progression towards developing heart disease. So we really want to be exceptionally aggressive in this group. So a lot of the preventive therapies that we'll consider, here's where we'll be even more aggressive about them. Here's where we'll actually even start thinking about some combination therapies. For example, in individuals with diabetes, where we'll be more likely to consider both an SGLT2 inhibitor and a GLP-1 receptor agonist to really try to reduce risk in this population. I want to emphasize that in the CKM syndrome construct, the staging represents kind of a qualitative approach to assessing risk, but we also have a very quantitative approach as well in a new risk calculator. And the details of this risk calculator will be described soon at the upcoming scientific sessions, but it really is one that reflects broader outcomes that are relevant to this CKM syndrome population, like not just ASCVD, but also heart failure, as well as some of the additional exposures that are of interest, like chronic kidney disease and some social determinants of health. So that's something that will be discussed more. But the reason why that's important in stage 3 is because individuals who have high predicted risk using this calculator will also be in this stage as kind of a risk equivalent, and a group where we want to really think intensely about very intensive of preventive care to reduce their likelihood of progressing to cardiovascular disease. I actually recently had a patient who had a significant excess weight as well as very advanced coronary artery calcification. And this patient, seeing the evidence of that subclinical disease and understanding the risk associated with that, really made dramatic lifestyle changes, lost a tremendous amount of weight, changed diet substantially, and was able to really have an improvement in many other factors. Now, coronary calcium, as many of you know, we don't often see all of that get better, but for subclinical heart failure measures, and certainly for the risk factors like albuminuria and metabolic risk factors in stage 2, we can actually often see a regression in these CKM stages. And it's important to recognize that we're not just trying to stop progression, but we're also trying to promote regression, which is more likely the earlier the CKM stage, but that can also have a substantial impact on the development of cardiovascular disease.
That's a great anecdote, Chiadi. And you're right. Data, when presented to patients in this way, especially those who fall in that very high risk category but haven't manifested it as clinical adverse events, is truly powerful. And there is so much value to instituting aggressive lifestyle modification and appropriate cardio-kidney metabolic therapies. When you look at the other side of the coin, you see patients in your prevention clinic, and you discuss the subclinical markers. In kidney disease, it's actually a little different. When you look at patients, the other part of stage 3 CKM, which includes the high and the very high risk CKD categories, a lot of these patients are seeing their nephrologist for the first time. and they already have stage 4 and stage 5 CKD. They're a couple of steps away from dialysis. They're already symptomatic. And it is such a missed opportunity, which goes back to the initial point that I made in the earliest stage, where we have patients in stage 2 where earlier screening and appropriate risk stratification would have gone a long way in preventing the progression of kidney disease. And this is so important because, once a patient comes in stage 3 CKM from a kidney perspective to a nephrologist, yes, there are therapies that we know work even in patients with more advanced kidney disease, but we sometimes don't highlight and think about this enough, that actually premature death, particularly from a cardiovascular cause, is the biggest competing risk for progression to kidney failure.
Yes.
In fact, in patients with diabetes and kidney disease, 90% of patients won't even make it to the point of kidney failure requiring kidney replacement therapy, whether with dialysis or with a kidney transplant, because they have already died. And they have died most likely of a cardiovascular cause. So when I see them as a nephrologist, my job is not to just slow down kidney disease risk, but it is to actually keep them alive, keep them well, keep them out of the hospital, and successfully eventually transplant those patients. So I really think that excess cardiovascular disease risk is so important, even from a nephrology perspective, whichever way you look at it. That is ultimately what those patients are going to suffer from. And then when you extend that stage 3 CKM to stage 4, which is patients with established cardiovascular disease, we look at phenotypes, including ASCVD, where we have also not just included coronary artery disease, but also peripheral arterial disease and stroke. Of course, the phenotype of heart failure, as well as atrial fibrillation, which clusters along with all these other cardiovascular disease phenotypes. And then we have further taken the next step to divide stage 4 further into patients with and without kidney failure. And it's important to spend a little time to understand why that nuance exists. And it is mostly because patients with kidney failure obviously represent patients at probably the highest risk category, for these events and recurrent events and premature death, hospitalizations, and poor quality of life. But interestingly, when you look at the data in terms of intervening across several of these risk factors, they are somewhat different in those from patients who do not have kidney failure, especially in those on dialysis. So I think the fact that we separated those two groups out is an important detail of our staging system.
Yeah, I think these are amazingly important points. And, I think the point of this approach, this staging system here, as you've described and we've said a few times, is getting people earlier in the process, implementing preventive therapies earlier, so to really improve those outcomes, not get people when they've already had that heart attack or when they're just about to go on dialysis. And then within stage 4, the other point, the reason why the CKM syndrome approach includes individuals both at risk for cardiovascular disease and also with existing cardiovascular disease is because for those individuals with existing cardiovascular disease, when they have CKM syndrome factors that are going to be unique treatment considerations. We've seen that for individuals who have obesity and cardiovascular disease, we're going to be thinking about, addressing that as in ways both through lifestyle. There's now emerging data for pharmacotherapies with the recent STEP-HFpEF trial, as well as the upcoming SELECT trial that's showing positive results preliminarily. We know that this is something we need to be addressing. When we see diabetes, we need to be thinking about SGLT2 inhibitors and GLP-1 receptor agonists for cardioprotective reasons on top of the other aspects of diabetes care. And then, of course, that's the case for chronic kidney disease. And you've just highlighted the importance of those kidney protective therapies and hypertension. The other thing I want to point out is that in this population, we haven't talked as much about LDL, which is obviously a really important aspect of prevention. And we certainly relate how aggressive we are in terms of LDL lowering therapies to the absolute risk of the patient. The patients with CKM syndrome, particularly those with cardiovascular disease, but even those who haven't yet developed cardiovascular disease, are often amongst the highest risk individuals. So we've talked about these stages of CKM syndrome, but in order to really personalize the approach to care, we also have to recognize that there's additional factors that are above and beyond the stages that can affect individuals' likelihood of progressing along this spectrum of CKM syndrome. So having a chronic inflammatory condition like lupus or rheumatoid arthritis can certainly increase your likelihood of progression. Mental health conditions, particularly things like depression and anxiety, can affect multiple aspects of your behaviors. Certainly the medications can even affect adiposity levels, but in multiple ways they can affect CKM syndrome progression. There's certain high-risk demographic groups. So we've talked a lot about low socioeconomic status as being a key predictor of CKM syndrome and complications from it, but also there's certain backgrounds like South Asian ancestry that we know have unique relationships with a high likelihood of developing CKM syndrome and complications. And then there are several sex-specific factors like premature menopause, polycystic ovarian syndrome, adverse pregnancy outcomes, and erectile dysfunction, all of those that are also big indicators of risk. I'll also point out that gestational diabetes is something that we've actually specifically called out in stage 1 of CKM syndrome, just because those individuals have such a high risk of having insulin resistance and progression of diabetes. So we actually put them with the people in stage 1 in terms of our screening approach for that population. So these are really all important because we want to make sure that while we have all these algorithms, we know that everybody's an individual patient, and we want to make sure that we, where we can, personalize our approaches for them in a way that best reflects their circumstances and their level of risk.
I think those are such excellent points, Chiadi. And, speaking of these risk enhancers, it is so important to use, and like we said, this CKM advisory and all the work that we have done in this space is relevant to so many different healthcare professionals. And I really think our colleagues in obstetrics and gynecology are a big part of the story. And like you said, when a woman develops a condition like preeclampsia, that is a failed endothelial stress test right there. And when you then project into the future and look at the cumulative risk of stroke or kidney disease, especially in those with recurrent episodes of conditions like preeclampsia, these are women that give birth to babies and then nobody is following up on, are they developing proteinuria? Are they developing diabetes? And many of these are already starting out after the pregnancy at stage 2 CKM.
Yeah.
And I really think that's an important point to make. While we also talk about risk enhancers, we have acknowledged upfront about the role that social determinants of health play as well. And just like we've been talking about dysfunctional and excess adiposity as being upstream to the development of cardiovascular-kidney-metabolic syndrome and instrumental in its progression, same thing for social determinants of health. These operate way before we see patients with established disease. And it is one of the highlights of this work and this very thoughtful work with experts in this space that we've put together, including in the soon to be revealed risk calculator. There is integration of social determinants of health measurement in a way that will just be able to incorporate that very important element into our overall CKM risk assessment and also interventions as we talk about multidisciplinary care and how we actually can intervene. Because it's not important that we just know that there are adverse social determinants of health, but what are we doing about it? How are we addressing it as a team? How do we intervene? What means do we have? So we also offer guidance on that multidisciplinary approach, but you can't really treat what you don't know exists. So I really think that is one of the truly important highlights of this work.
This is so key to our understanding of risk, that we need to think about things not just from a biological standpoint, but clearly from a social standpoint. I care for individuals here in Baltimore at Johns Hopkins, and and you're trying to think about making suggestions for healthy lifestyle in terms of what you're going to eat and where you're going to exercise and the challenges. There are so many structural and built environment challenges that make that more challenging for patients who I often see in my clinic space. When you talk about being able to afford your medications, when people are just thinking about keeping their lights on, or are dealing with multiple jobs and sometimes limited interpersonal support, these are really big challenges. When copays, even not large copays, can have a really big impact on whether somebody chooses to get a medication versus put food on the table. Addressing the social determinants is fundamental to really thinking about CKM syndrome. So I'm really happy that that's infused its way into so many aspects of our care approach. And I think as we've talked about this staging, it's really important to understand that screening is really absolutely necessary for this CKM syndrome approach. And that's really because so many individuals at these earlier stages are asymptomatic. Being asymptomatic, unless we go looking for these factors, we won't be able to address risk early. I think first it's important to recognize that we split screening into biological screening as well as screening for social determinants of health. And we also split up screening into early life and adulthood approaches. So we're screening in both populations. And for early life, we are aligning with the approach by the American Association of Pediatrics. And then in adulthood, in particular, I think the most important takeaway is that the intensity and the frequency of the screening is matched to the CKM syndrome stage.
I think those are great points. And along with the part about screening, which you eloquently described, Chiadi, also goes hand in hand developing a good risk prediction algorithm. And we've stated up front that, cardio-kidney-metabolic syndrome has multiple elements to it, and there are different ways to predict risk. But it's important that risk prediction go beyond what we currently do in the clinical setting. And I'll just quickly go over some of the limitations of some of the existing excellent work, but where the needle really needs to be moved forward in the field. For example, the currently used pool cohort equation predicts the risk of having a heart attack or stroke in the next 10 years and specifically targets people aged 40 to 75 years. It uses traditional risk factors like age, sex. It does include race, cholesterol, blood pressure, and yes and no answers to smoking, cholesterol medication use or blood pressure medication use, and diabetes. In the updated model that is proposed and will be unveiled during scientific sessions, there are some novel aspects, including baseline incorporation of measurement of kidney function, more detail to type 2 diabetes beyond a mere yes or no, as well as just what we talked about, measurement of social determinants of health. And I really think one of the biggest highlights of this new model is that we are proposing to look at risk in individuals as young as 30 years of age. And especially with the shifting dynamic and the clustering of these cardio-kidney-metabolic risk factors, I think all these innovations will truly take this field forward.
Now, I think a next question for all of us is, how can we put this information to use? So part of our advisory also includes a call to action. And this call to action really emphasizes patient-centered implementation with a particular focus on aspects that we've been discussing, such as the consideration of social determinants of health. We emphasize that as a priority area that should guide care. That needs to be people on the healthcare team that actually address the social determinants of health issues that are identified for patients. We need to systematically leverage community resources to address social determinants of health needs. And this is something that we want to make sure starts happening systematically, starts being integrated into our health system. And it's important that if we want to have a real world impact for what we're doing, that we do not separate out the social determinants of health from our clinical considerations. They're all combined. We have to think about the whole person, and that's really important part of optimizing CKM health.
It's such an important point, Shadi. And another major call to action is to reduce the current state of fragmented care. And we have touched upon this earlier, where we show this very elegant confluence of pathophysiological pathways and the interplay between multiple organs and the very holistic approach, the clinical approach to being able to benefit the patient as a whole as opposed to by organ system. But then when you look at how this actually gets implemented, how it actually gets translated into care in the community, it is really siloed. We have a patient that has a primary care clinician who then gets referred to multiple specialists, just like the patient that you described, who had no idea why she was unfortunate enough to earn a visit to an endocrinologist and a cardiologist and a nephrologist. And the likelihood is those three specialists are probably not communicating with each other. Sometimes those communications may actually have different recommendations, steering the ship in discordant ways. Communications don't go straight to the primary care physician. Electronic records also don't help in the fragmented system that we practice in. So when you put a patient with cardio-kidney-metabolic syndrome in the center of this mess, needless to say, it is a major reason why our outcomes are so dismal. So one of the things that we have proposed, we come up with this concept of what is called value-based and volume-based care. What does value-based care mean? We propose that patients, if they meet any two out of these three CKM criteria, either they have cardiovascular disease or risk, or diabetes, or kidney disease, they get funneled into a multidisciplinary care team that includes representation from these specialties, cardiology, nephrology, and endocrinology, all working in tandem with the primary care clinician and supported by a clinical care coordinator who is involved in helping the patient navigate this really complex system and ensuring that not only are they being screened for adverse social determinants of health, but the appropriate evidence-based guideline-directed therapies are being delivered upfront. So these are generally lower risk patients, but enough that they merit a concerted evaluation and have a care pathway in plan. And then we also propose criteria to refer patients to consultants for what we call volume-based care, because one of the big problems in the United States, Chiadi, is that there is huge disparities in access to these specialists. Depending on where you live. For example, in Washington, D.C., the ratio of nephrologists to patients is 1:50, and then in other places it could be 1 in 5,000. So, we have to have models that can serve patients living in rural areas and urban areas, primary care physicians who may not have the necessary support, and those that do, academic hospital settings, smaller community settings. So we really have to cater to a lot of variability in practice settings. And that's why we came up with value-based and volume-based care models.
Yeah, and that's really helpful description of that, and complementary approaches to try to really bring subspecialty perspectives together to support the whole patient. There's other important elements of our call to action. So the first is really addressing research gaps, and some of that is mechanistic gaps and understanding some of the pathways leading to development of cardiovascular disease and kidney failure and CKM syndrome, and understanding the factors that really impact progression along those CKM stages. Also, how we educate the public and healthcare professionals, improving obesity management, which we've identified as at the root of a lot of CKM syndrome. Improving access to pharmacotherapies is a really powerful challenge to address as well, because even while we have all of these recommendations, we know that there are some real challenges for many individuals with getting access to these beneficial and kidney protective and cardioprotective therapies. So understanding how we can improve access to those therapies is quite key. And then I think as we're talking about ideal cardiovascular health, we really think it's important to bring stakeholders together and develop partnerships to support the achievement in ideal cardiovascular health across diverse communities so that individuals from various settings can have equitable opportunities for optimal CKM health.
That was very nicely summarized, Shadi. So that is our overview of this AHA Presidential Advisory on Cardiovascular Kidney Metabolic Health. And you can find the full advisory online at professional.heart.org. I want to put in a plug-in for the fantastic AHA Kidney Council, which I am the chair of, and I want to encourage all listeners to check out the Kidney Council content at the upcoming scientific sessions, where a lot of this cardio kidney metabolic theme-based materials will be presented. I really think you will find the sessions really engaging. When I think about what the top takeaways are from this body of work, I think the first is what Chiadi and I have really reiterated multiple times. It's about holistic care of the patient with cardio-kidney-metabolic syndrome. We really cannot have a piecemeal, non-synergized approach anymore. There is an urgent need for rapid deployment and implementation of high evidence-based guideline-directed therapies, and we, for the first time, have this amazing opportunity to make a true dent in the disease burden, the excess premature mortality, and adverse cardiovascular disease events in this very high-risk population. The second takeaway point for me is that the way in which we practice in this fragmented healthcare system really needs an overhaul. This siloed approach to the care of the CKM patient simply cannot keep going on, and we are not doing the patient a service, and we truly need to align our mutual knowledge, our mutual interests, and our mutual targeted therapies to achieve that common goal in the most patient-centered way that is possible, in the most equitable way that is possible. Chiadi?
That's really beautifully said, Janani. And I think, there's a couple of things that I want to emphasize as we kind of, conclude here. One is thinking about the concept of harmonization. We've talked about how much there's one of the big elements that I think, there's a couple of things that I want to emphasize as we kind of, conclude here. One is thinking about the concept of harmonization. One of the big elements that comes to play in this fragmentation is people reading from different playbooks. And one of the things that was a big focus of ours is, first of all, bringing folks together from different disciplines so that we had all those perspectives represented in the same room to really make sure that we weren't just thinking from the cardiologist perspective or the primary care doctor perspective or the endocrinologist perspective or the nephrologist perspective, and bringing those all together. And the guidelines that we looked at were guidelines from all of the major societies, just with a focus on actually having us all come together for the sake of patients. So harmonization was key to the algorithms that were developed in our process, and hopefully really reflecting also the key needs of this population. The other thing I want to emphasize is the life course approach. We want to consider this in the youth setting as well as among adults. Catch people earlier in the stages. We don't want to just be addressing individuals when they have stage 4 or 5 CKD or when they've already had their heart attack. So there's really a focus on early identification and prevention, and as part of a holistic approach, not just the biological factors, but also the social factors that drive the development of CKM syndrome in the population. So those are really some of the core tenets that we hope you can take away. And we're really so grateful to all of you for listening. And we hope that this inspires you to think of cardiovascular kidney metabolic health, or CKM health, in a new way, and to work with us to address this very important and exceptionally common issue in the population. Thank you very, very much.
The data and statistics presented in this podcast are from the official guideline being released by the American Heart Association. Any and all personal stories and testimonies are that of the talent, host, and volunteers, and are not reflective of any statements or position of the American Heart Association. For a full manuscript of the guideline released, please visit the official American Heart Association website at professional.heart.org.